Good afternoon, everyone, and welcome to our Bay State Health Heart and Vascular Lecture Series, our second week for 2023. My name is Heidi Zalai, and I'm a clinical exercise physiologist here at Bay State Health in cardiac rehab in Springfield, Massachusetts. We are happy to have you who can join us live today, but did want to make sure that you are aware for this presentation and those previous and those following. It has been recorded, so it will be available on the baystatehealth.org website. Should you or anyone like to view this presentation in the future. You can also register for any of our upcoming lectures and videos in the same area at the baystatehealth.org website. Following this presentation, we do welcome your questions as always, and we will address them at the end of the presentation. On your screen, you should have an area that has Q&A, and maybe at the bottom of your screen or on the right-hand side of your screen, depending on how it's set up. And you can type your question in there, and again, we'll address as many of the questions as possible at the end of this presentation. We just ask again that you keep them pertinent to the topic at hand today for Dr. Wasserman. Finally, you will be able to have the opportunity to provide comments and feedback about today's presentation immediately following our presentation. I'd like to introduce our presenter today. We are very thankful to have Dr. Brian Wasserman with us. He is a cardiologist here at Bay State Health, and he's going to be talking to us today about the latest tests and technology that are used in cardiac imaging. Dr. Wasserman received his medical degree and training at Vanderbilt University School of Medicine and Vanderbilt University Medical Center in Nashville, Tennessee. He specializes in the multiple aspects of cardiovascular disease, especially cardiac imaging here at Bay State Health. So we thank you, Dr. Wasserman, for joining us today. We appreciate your time.
Thank you for the kind introduction. I'm also one of the medical directors for information and technology in the hospital, so if my slides don't work, it'll be extra embarrassing. So welcome, everybody. Thank you for spending some time on Super Bowl Sunday to listen to this talk on advanced cardiac imaging. And I have no conflicts of interest to disclose. So the goals of this talk are to give a little bit of background knowledge on the different cardiac imaging modalities, echocardiography, nuclear cardiology, coronary angiography, cardiac computed tomography or CT, and cardiovascular magnetic resonance imaging or MRI. Compare some of the uses, some of the strengths and weaknesses. Hopefully you all can learn a little something, and even better if I can learn something from you and have fun. And there are lots of bad puns in medical jokes, and this is one of my favorites. So Winky back at the type of heart block. So, really the history of imaging for medical purposes goes back to 1895. Wilhelm Röntgen, who was a German professor, first discovered the X-ray, and the first ever X-ray taken of a human was actually the same year that X-rays were discovered in 1895 of his wife Bertha's hand with her ring on here. And I guess true love is trying out the first X-ray on your wife. I don't think that would fly these days. Things have gotten more complex since then, quite a bit. While that's good because there's a lot of different ways to get to the information, it is more confusing for providers and for patients. So, coronary angiography, which is invasive to look at the blood vessels, echocardiography, which is using sound waves to measure velocity and look at the structures of the heart, cardiac MRI using magnetic fields, nuclear medicine, which utilizes both X-ray and nuclear tracer perfusion, and then cardiac CT with reformatting to show the 3D structures of the heart and the coronary arteries here. So there's a lot of options. There's a lot of good options, but it can be a lot for patients and providers to try and all keep track of. Throughout cardiac imaging, there are charts like this the specifics are less important than just the general overview of, there are many different types of cardiovascular disease. There are many different types of imaging, and there's overlap. While cardiac MRI might be the best test for volumes, echo is also utilized often, and valvular disease is often a multidisciplinary approach. So there's a lot of different reasons to get different tests, and the different indications and contraindications will often determine which test we order, when, and why. I don't want you to feel like this when you're talking to your cardiologist about cardiac imaging. So to start is echocardiography. And there's two main types of echocardiography. There's transthoracic, in which a probe is placed on the skin from the outside, like in that top picture, which can be done both as an outpatient or inpatient. And there's stress echocardiography, where images are taken before and after stress, which can be exercise or medication to simulate exercise stress. The other main type of echocardiogram is the transesophageal echocardiogram. I do these frequently. It is when we go in with a probe into the esophagus, which lays directly behind the heart, to take images. And it's invasive. It is not, surgical, but it's an invasive procedure that can be done as an inpatient, or for outpatients, they come in to day stay and are checked in like a lot of outpatient procedures. The advantage to transesophageal echocardiography is we get a better look, especially at structures in the back of the heart. So valves, and also looking for blood clots and things like that. So the general principles of echocardiography, it's ultrasound, and the important part being sound. So it's sound waves. There's a lot of overlap with echolocation, which is used by bats and whales, in addition to sonar used for naval purposes. Echocardiography really started in about 1960 with one-dimensional or M mode. And then in the early 1970s, two-dimensional echo was utilized, and then Doppler echocardiography, which was a major step forward. So the transducer sends out sound waves and then receives them. And sound waves, depending on what kind of material or tissue they're going through, can do different things. Some sound waves are reflected back to the probe, and those are the sound waves that end up creating the image that we'll see here in just a little bit of the echocardiogram. They can also refract. Since sound waves, they behave like light waves. So if you've ever put a straw diagonally in a cup of water and you see how it looks like it's broken, that's refraction. They can disperse, so be scattered in different directions by the material. They can be absorbed so that they're not reflected back to the probe, and they can diverge, which means, from a central point, they're at a different angle, which the further away from the probe that we get, the more lateral distance the difference will be. And based on what is and isn't reflected back to the probe and the imaging software that's on the actual echo machine will create an image. So the Doppler effect is something that's very important in cardiology. Especially we use it for tracking red blood cells. So one of, if not the most important principle of cardiac imaging is that the heart is a moving structure. It's beating very frequently, and it's pushing blood around the body, which is its major task. So when blood cells are moving toward the probe, their wavelength decreases, and when blood cells are moving away from the probe, the wavelength increases. And we can utilize this property to determine how fast the blood cells are moving. Doppler is used often in weather, meteorology. Also, it's the principle that explains why if something like a car or a train is coming towards someone and then starts and it goes past the individual, the frequency will change as it moves towards and then past. This is an example of a fairly normal two-dimensional echocardiogram image. loop a couple times. So using sound waves and the differential properties, the transducers here on the chest, and then there's chest wall, subcutaneous tissue, ribs, and then the heart's here. So this is the right ventricle of the heart that pumps to the lungs. This is the left ventricle that pumps to the body, the aortic valve, and the left atrium. And we can see the difference between the myocardium, which is the heart muscle, and the blood pool here, based on the differing properties that each of them imparts on the sound waves as they go through and then come back. So this is a color compared Doppler sequence on the same patient. Again, fairly normal. The left image is just a two-dimensional apical image. So here the transducer probe is put near the apex or tip of the heart. And then as the sound waves are going up to the top of the atria here. And again, we can see the differing properties of the heart muscle here. This is the mitral valve here. And then this is tissue behind the heart. And on the right here, this is the Doppler image. So moving towards the probe is red. Moving away from the probe, it's blue. And we can see here, we can tell which direction blood is going. So here, the mitral valve is open and blood is going towards when it's red, it's going towards the left ventricle. When it's blue, it's going away. And the scale here, the brighter the red or blue, the faster it's moving. So we can get an idea by color Doppler, which is what this is called, of which direction blood is going and how fast. So often we will use Doppler echocardiography to evaluate cardiac valves. The smaller an orifice is, the faster blood will go through it. So you can imagine the chamber is much larger than the valve, that the chamber is either receiving blood from or sending blood through to get to the next area of the body. So this is a patient that has what's called aortic stenosis. So partial obstruction of the aortic valve, which goes from the left ventricle to the aorta, the major blood vessel of the body. Here we can see where my cursor is that there's a very calcified valve. When there's a lot of calcium, it's difficult to assess visually using echocardiography because of the scatter principles that we talked about before. It does not come back and reflect as well as in other tissues. So this patient was evaluated and ended up having a transcatheter aortic valve implantation, or TAVI, which is the shorthand. And again, here, there's a valve replacement here, but it's difficult to see. There's metal and foreign tissue that, again, doesn't reflect the blood back as well as we would like. So one of the ways that we can utilize echocardiography in this situation is called spectral Doppler. So this is looking at a quantitative graph of how fast the blood cells are moving. We can see before the transcatheter aortic valve implantation, when the diseased valve was present, the velocity was very high, meaning that the valve was very small in the amount it opened. You can see the velocity here is 400 centimeters per second or 4 meters per second. And this was evaluated off of this image here. So this was used to get the spectral Doppler, and then same for the post. And you can see the velocity there is now about 150 centimeters per second or 1.5 meters per second. So it's come down significantly. And the patient improved. They had shortness of breath when they exerted themselves, which was one of the reasons to have the aortic valve implantation done. And then afterwards, their symptoms had resolved, and you can see that reflected in the decreased velocity, which also means decreased pressure that's lost across that valve. So that's section one on echocardiography. The next part of the presentation, we'll be talking about nuclear cardiology, nuclear cardiovascular imaging. When people say nuclear stress test, this is what they're referring to. So really started around 1972. And there's two main ways that we can stress the heart. Usually what's preferred is exercise. So this is an example here where a patient will be put on a treadmill, and EKG leads will be hooked up, and they'll have a real-time EKG running the entire time they're doing the stress test. And then every few minutes, usually every 3 minutes, the treadmill will go a little bit higher, more incline, and a little bit faster. And we'll try and go until the patient, can't go any further, is completely tired out. We want to get to at least 85% of the maximum predicted heart rate, which is based on a formula. If patients can't exercise due to injury, we can use different medications, which is called a pharmacological stress test. In general, we prefer exercise because that's the actual stress and the way that the body receives it. So if we can evaluate during exercise, we can get an idea of what the heart's doing when it's being taxed by physical stress. There are a couple different types of cardiovascular imaging. There's SPECT, which is single photon emission computed tomography, or PET, which is positron emission tomography. They're very rarely written out all the way. It's usually just SPECT or PET. So what happens is the patient's given a very small dose of a radioactive tracer. And that tracer has decay properties, and it'll go where blood goes. So the tracer's given a very small amount, and images are taken at rest, and then tracers given again at peak exercise, and we look at if there's any difference in the blood flow or perfusion between the two. So this is an example of a normal stress test result. You can see for all of these, the top is stress, bottom is rest. And this is as we move through the heart in different planes. This is what's called a short axis image, where we see the little donuts. This is a horizontal long axis. This is a vertical long axis. You can think of the heart kind of as a half of a football shape, being that it's Super Bowl Sunday, that's appropriate. So this is cutting the short way, this is cutting the long way, and this is cutting on the other axis. So the important thing here is that there's no significant difference between the rest and the stress images on any of these. If we see an abnormality at rest, that's also there with stress. That usually means a heart attack that's happened previously. If we see an abnormality with stress that's not there at rest, that's concerning for what we call ischemia, which would be decreased blood flow under stress. So this is an example of a positive stress test for ischemia. Again, top is stress, STR, bottom is rest, RST, for all of these, and it's always helpful when they put the arrows here for us. I think it's probably easiest to see in this vertical long axis image here, but this is very normal perfusion at rest. Donut looks great and full here at rest. The half of football looks great, and then we see with stress that the entire anterior wall of the heart is not receiving tracer, which means it's not getting enough blood flow. And we can see that here and here and here. And the important thing to realize is this is comparing the different walls. So we know this is getting less than this inferior part. So this is a very highly positive nuclear stress test for ischemia. And typically patients that would have this finding would go on to cardiac catheterization, which is what we're talking about next. The cardiac catheterization is an invasive procedure. In the cardiac cath lab, one of our invasive or interventional cardiologists will get access with a sheath either through an artery, if it's a left heart cath, looking at the part of the heart that pumps to the body, or a right heart cath would be through a vein to look at the part of the heart, the right ventricle that pumps to the lungs. And a right heart catheterization, often they'll go in through the jugular vein or the basilic vein down here, and we're able to do pressure assessments to look for any evidence of high pressures in the arteries to the lungs and in different sides of the heart to try and come up with the reason that patients are having symptoms. A left heart catheterization through the artery, so often the radial artery in the wrist, traditionally for a long time, the femoral artery in the groin was used, but over the last decade or so, we've really moved to more radial access because the complication rate's lower, and it's less, there's less complication rate for the patient, and it's less uncomfortable. I'm not going to say it's comfortable, but basically a sheath is a larger IV that goes into the artery for a left heart cath or a vein for the right heart cath, and then a catheter, which is a long, flexible piece of plastic, will be placed into the arterial or venous system. For left heart catheterization, pressures are also checked on the left side of the heart, but coronary angiography can also be performed. So with coronary angiography, radio-opaque dye, which is commonly known as contrast, is given to the patient. There is a risk of allergy. There's iodine in the contrast, so a contrast allergy usually applies to most types of radio-opaque dye. There is a small risk of injury to the kidneys. So typically before a left heart cath with angiography, kidney function will be checked. In patients that have abnormal kidney function, special considerations may be made. And then it's a two-dimensional X-ray. So we're able to visualize the flow through the coronary arteries as we're injecting the contrast dye, and then see if there's plaque or calcium there. A good thing about coronary angiography and cardiac catheterization is that if an intervention is required, such as a stent, oftentimes it'll be done through the same sheath with a different catheter, but at the same time. And also structural interventions. So again, over the last 10 to 15 years, aortic valves, clips on the mitral valve, among others, are able to be done percutaneously, meaning through the blood vessels rather than always with an open surgery. And usually the discussion of which way to go depends on the patient characteristics and preferences. And for example, for a transcatheter aortic valve implantation or a mitral valve clip, a surgeon and a cardiologist typically will discuss with each other and with the patient what they think the best route. This is an example of coronary angiography. So this is the catheter here where dye is injected. And we can see that the left main coronary artery is where the dye is injected to, which is short right here. And then it bifurcates or splits in two into the left anterior descending artery, which is this one here, and the left circumflex coronary artery, which is here. The left anterior descending, or LAD, supplies the front wall of the heart, and the left circumflex typically supplies the back of the heart. You can see there's an abnormality in the left circumflex here. It was called a 95% stenosis, and this patient was having symptoms of chest pain and shortness of breath. So immediately after the angiogram, the catheter was changed for a different catheter, and then a percutaneous coronary intervention was done, or PCI. You can see this is the new catheter that was put in, and then a wire is advanced down the artery past the blockage, right there. Blockage is right here. The wire goes across it. And then a stent with a balloon is placed in the area of the blockage and inflated. And here we can see the difference between before and after, with that 95% blockage before and a very good result post with no significant blockage, and there's a stent there. So another way to evaluate for blockages in the coronary arteries is cardiovascular computed tomography, or CT, CAT scan, people also will call it. I'm going to play this short video here showing an example of a patient going through a cardiac CT scanner. So you can see the patient's on the table that's moving up and down, or back and forth, while the CT scan is spinning to obtain data in different planes. We can get 3D reconstructions like that image to get an idea of the vasculature in and around the heart. So cardiac CT was first used in its modern iteration around 1996. It works on X-ray principles. The major difference is that you're taking x-rays from multiple different angles. So instead of the angiogram here, so here's an example of an angiography setup in the cath lab. So there's an x-ray assembly here where x-rays are emitted from below and they're detected up on top, and a real-time two-dimensional x-ray can be obtained. And to get different views, this is C-arm is what it's called, is moved at different angles, and then multiple pictures are taken at one per angle. But the main difference between that and a CT scan is the CT scan is moving while it's obtaining the image.
In contrast,
so this is an example of a patient with the patient's head and shoulders inside of a CT scanner. So there's an X-ray tube here that rotates around while all of these detector rings here can determine how much of the X-rays pass through versus are blocked by the different structures, and they can be used to recreate a 3D image or an image at any different plane. An important concept is also gating, G-A-T-I-N-G. So cardiac gating is where an electrocardiogram or ECG is done, and the CT scanner knows what part of the cardiac cycle the patient is in. And this is important for a couple of reasons. Number one, because the heart's always moving, it needs to know which phase of the heart, so systole, pumping, diastole, filling, it's in. But also, if you can obtain multiple different images at the same point in the cardiac cycle, you can lay them over each other to increase the resolution significantly. So the cardiac CTs have gotten much better as far as clearer with different gating algorithms. There are two main uses I wanted to touch on. Number one would be a coronary CT calcium score. So this is a non-contrasted CT scan, and it's used mainly for risk stratification. So there's a lot of different calculators that can be used to assess cardiovascular risk. I typically use the ASCVD risk algorithm from the ACC, American College of Cardiology, American Heart Association, among others. Most of this data was obtained from the Framingham Heart Study. And it uses age, sex, race, blood pressure, total cholesterol, HDL, or quote unquote good cholesterol, history of diabetes, smoking, and if the patient is on therapy for hypertension, to come up with a number for what's the estimated 10-year risk of a heart attack or death from a cardiovascular cause. And actually, this app is available, ASCVD, for, I know for iPhone, and I believe for Android as well, that clinicians or patients can use it to assess what their estimated risk is. For patients who are low risk, in general, healthy lifestyle is promoted. For patients that are high risk, usually medication therapy is advised, and that would include statin medications or other cholesterol therapies. We've found over time that really when we're treating cholesterol, we're treating cardiovascular risk. And even if someone's cholesterol is normal or mildly elevated, if they have other risk factors, they do better if they're treated with a statin medication or some other cholesterol lowering therapies, not all of them. But some people are in the intermediate risk category. So it's difficult to assess if they would benefit from medical therapy or not. And some patients have, risk factors that are not in the traditional ASCVD risk algorithm. Most commonly would be a family history of early coronary disease. Myocardial infarction or heart attack before the age of 65 in a female, before the age of 55 in a male, or especially very young heart attacks or stents. They're not reflected in this risk score, but certainly they're a risk factor. So in patients that have either intermediate risk or there's concern for risk that's above the calculation, a coronary calcium score can be done. It's a very quick procedure, and we're talking in the realm of minutes for the patient, and we're able to see calcium without contrast. Calcium shows up very well on CT scans. And there's three major results. We can see a coronary artery calcium score of 0, which is in this upper left here, in which case the risk of an event in the next 5 years is low. And typically, if patients have increased risk based on the ASCVD algorithm or other concern, it could be repeated in 5 years, but medication therapy is not often advised unless there's other factors that are at play. A coronary artery calcium score of greater than 100 or greater than 75% for age and gender matched patients. Usually statin therapy is recommended, and if patients can't tolerate statin therapy, other therapeutics, sometimes aspirin. Many people know the aspirin data has been back and forth for patients that have never had a heart attack. If someone's had a heart attack in the past, it's very clear that there's benefit from using aspirin. And the other possible result is, mildly abnormal coronary artery calcium. That would be 1 to 99, or less than 75% of predicted. Usually statin therapy is recommended for these patients. Usually aspirin is not. And the computer basically will calculate or count up the number of pixels that have this bright signal from calcium in the cardiac field where the coronaries are. And it gives a number. So the score reflects how much calcium. Obviously, there's a lot more calcium here than here, and this is between the two. So very helpful for risk stratification. So coronary CT angiography contrast is used, and it's radio opaque, iodinated contrast. So there is a risk of allergy and a small risk of kidney dysfunction after using it. With any CT scan, there is radiation, although cardiac CT calcium score is fairly low radiation. CT angiography is a bit more, but still not considered very high. One reason to use it, it's lower risk. There isn't risk of a vascular complication like there is in cardiac catheterization. A downside would be if you find an abnormality, you can't fix it then because there's no catheter in place. So coronary CT angiography is very useful as a rule-out test for patients that come to the hospital with chest pain that might have one other abnormal finding. If the coronary CT angiogram is negative, then it's a very low risk that they would have a cardiac event. So in general, CT angiography is used for symptoms or abnormal tests, and coronary artery calcium scoring is used for risk stratification in patients who are asymptomatic. Also, if patients have known disease, it can be evaluated with CT angiography. Certain patients have difficult anatomy to access with a catheter. So using CT angiography is, you can format the plane in any 3D direction. So it's very helpful in those respects. Patients have congenital or structural abnormalities of their heart or of their coronary arteries are evaluated very well, again, because you can reconstruct. And then pre-procedure planning. So basically all patients who are getting a transcatheter aortic valve implantation will have a cardiac CT done to look at the aortic size, for what size valve they should get, and things like that. So this is a case of a patient at Bay State who underwent coronary angiography as part of a workup for an aortic valve replacement. They had an abnormal echocardiogram, and then they had angiography as part of that workup. And this is a very abnormal coronary angiogram. Not for any blockages, but was it here? So this V or U shape here is very abnormal. Typically, the left anterior descending, or LAD, that goes to the front of the heart would go straight across here. So with seeing this, it was unclear where the course of that artery was, and if the patient's shortness of breath, which is what had them evaluated for the aortic valve replacement in the first place, was possibly caused by either a blockage here or interference with the vessel when the heart was pumping. So this is a CT coronary angiogram here. So this is rotating around, laying out the LAD. I'll pause it. So we can see here, the left anterior descending, or LAD, is going through the heart muscle in the interventricular septum, which is the part that's between the left and right ventricle, which is very highly abnormal. But we see there's no significant disease in it. And it doesn't look like there's any blockages or stenosis to explain the patient's symptoms. And then this is just a reconstruction of the coronary tree. Again, so here's the right coronary artery that supplies the bottom wall of the heart and also the right ventricle. This is the left anterior descending with that abnormal course going to the front. And here's the left circumflex going to the back of the heart. Let's play here. And the ability to reconstruct this also told the clinicians that even though this left anterior descending went into the muscle here, it's not in a place that would be dangerous if the valve was either replaced or surgically or with transcatheter. It's not going in an area that's in danger if you were to work on the aortic valve. So for pre-procedure planning, that was very important. And the patient ended up getting a transcatheter aortic valve implantation. Okay. So the final modality we're going to talk about is cardiovascular magnetic resonance imaging, or cardiac MRI. This is my advanced imaging specialty. I did an extra year of training just in cardiac MRI, and I interpret cardiac MRIs at Baystate, in addition to echocardiograms and performing transesophageal echocardiograms. So cardiac MRI really was first used in the 1980s with any sort of success. That was partially due to the gating that we talked about before. Before that, there were non-gated studies that just weren't that helpful. But really, it's been, I'd say, from the mid-90s on that cardiac MRI has taken off. So cardiac MRI is a different, or any MRI, is a different, the physics are different. So we're using a magnetic field rather than X-rays or sound waves. One of the advantages of cardiac MRI is that we can assess the myocardium, which is the heart muscle, very well. So we can look at a myocardial infarction or heart attack. We can look for what's called viability. So if we fix the artery that caused the heart attack, do we expect that part of the heart function to improve or not? We also can look for inflammation. So one cause of that would be myocarditis. And then infiltration, so things like cardiac amyloidosis, sarcoidosis, and hypertrophic cardiomyopathy. So oftentimes, a cardiac MRI is done after initial testing with an echocardiogram and possibly cardiac catheterization has shown there's abnormalities and we don't know why. Also, with cardiac MRI, we can measure blood flow to look at valve disease and specific valvular regurgitation or leaky valves. So echocardiography is the test of choice usually for valvular stenosis, which is a valve that isn't open normally. Cardiac MRI is one of the tests of choice for valvular regurgitation, or valves that don't close normally and leak. Also, we can look at perfusion, so somewhat similar to the nuclear stress test of what the blood flow looks like to the different parts of the heart. There are institutions that do stress MRI. We are currently not one of them, but hopefully that will be available in the future. So the general principle of cardiac MRI is that when you apply a strong magnetic field, water molecules will line up with the field. Most of them in the same direction, but some will be opposite. But without a field, they're basically randomly pointed as far as where the charge is. So after you have the strong magnetic pulse, they'll go back to a random setup. How long that takes will depend on what kind of tissue is there and how much water specifically is in that tissue. We can give contrast, you don't have to, which is gadolinium, which is separate. It's not related to the iodinated contrast used for catheterization and used for cardiac CT. So if a patient has an iodine allergy or an allergy to iodinated contrast, they can still get gadolinium contrast. There was a very rare disease that called NSF, or nephrogenic sclerosing fibrosis, that was seen with some of the older generations of gadolinium contrast that we do not see anymore. So even with patients with reduced kidney function, we can use gadolinium contrast, and it does not damage the kidneys. And we look at both the real-time perfusion, so as the contrast is going in, where does it go? And delayed. So after a period of minutes, is the contrast staying anywhere? Which usually indicates scar or fibrosis or inflammation. Normal heart muscle takes up contrast very quickly and then gets rid of it very quickly, but it binds to scars. This is a fairly normal cardiac MRI, just to be oriented. So most of the cardiac MRI views are very similar to echocardiogram views. So, and that's done on purpose, so they can be somewhat compared. This is what we call a two-chamber view. So this is the left ventricle, this is the anterior wall, this is the apex, this is the inferior wall, mitral valve, left atrium. We can see this heart's pumping fairly normally. We don't see any wall motion abnormalities. This is a four-chamber view of the same patient. And again, so we're seeing the left ventricle and the right ventricle here, as well as the atria. Okay, this is a perfusion sequence on the same patient. So here we're looking at what the contrast does right after it's injected. Allegedly. Okay, there we go. So we can see, and these are different views that are all taken during the contrast injection. So we can see the contrast goes in the right side of the heart and then the left. The heart muscle takes up contrast and then gets rid of it quickly. These are delayed enhancement images here. So after the contrast perfusion, we wait usually in the order of 5 to 10 minutes and then look for any enhancement, which would be bright on these images here in the heart muscle, and we don't see any here. You can see this is actually what's called blood pool artifact. So between the heart muscle and the blood pool, you can get some artifact, but this is a very normal delayed enhancement imaging there. So this is another case where a patient first had a cardiac catheterization. So this is a very abnormal catheterization. So here, there should be a blood vessel supplying this area here and this area here. So the LAD, or left anterior descending, is completely blocked right after this diagonal and this septal perforator come off. So this vessel should continue all the way down to the tip of the heart from there. And likewise, there should be the circumflex coming into here, and that's completely blocked at what we call the ostium, or the start of it. So there are two severe blockages. Should we fix them? Which one should we fix, and how should we fix it? Surgical or percutaneous, meaning with stents, or should we not fix it and treat with medications? So this was the same patient's cardiac MRI. So we can see the apex of the heart, which is where the LAD supplies here, is what we call dyskinetic. So when the heart muscle here comes in, this goes out. Usually that means it's scar. And again, we can see that on this four-chamber view here. As the heart muscle comes in, the septum, the lateral wall here, we can see this thinned area goes out. Also, there's a mass here at the tip of the heart. And these are the delayed enhancement images. And we can see here, the red arrow, this area should be roughly the same thickness as here. So this is the area of myocardium or heart muscle, this thin rim that's still alive. And the rest of this area is all infarct, or it's scar, basically. Also, with the yellow arrow, there's a blood clot inside the wall of the left ventricle right here, which we typically see with non-viable or infarcted or scar. You don't usually get a thrombus that forms on heart tissue that's viable because the heart tissue is still pumping somewhat. And again, you can see the red arrow corresponds on this view to over here. So there's the enhancement. You can see it actually better here. All this area here of white or bright is delayed enhancement, and this is that blood clot at the apex there. So this patient did not undergo stenting or bypass surgery because it was thought to be high risk without a lot of perceived benefit. The patient was put on medications to help their heart function recover, and also blood thinners for that blood clot in the apex of the heart. And then one last case here, this is a patient who had an abnormal echocardiogram, which showed low heart pumping function, and then a cardiac catheterization that did not show any blockages. And here in this two-chamber view, we can see very abnormal heart function, very low. And the entire heart is not pumping normally, and there's an abnormality here in the anterior or anteroseptal part of the heart that was not seen on echo. And again, we can see the abnormality here, and the heart function is severely reduced. It's somewhere in the neighborhood of 10 to 20%, and normal is 55% or above of the blood that comes into the heart gets pumped out. So very severely reduced heart function. Because of that, the left ventricle here has dilated. It's very big, so that because it pumps so poorly, to get enough blood flow, it had to remodel and become a larger chamber. And again, so we see these images here. So the bright would be delayed enhancement here. And the dark, again, is a thrombus or a blood clot inside the heart muscle. I'm sorry, inside the left ventricular chamber, adherent to the heart muscle, so sticking to the heart muscle. And one thing that can give you this is a heart attack, but this patient did not have any significant disease on their cardiac catheterization. So this is an inflammatory process. We're not sure yet. This could be myocarditis. This could be cardiac sarcoidosis, but they're undergoing further testing to work that up. And again, this is just the short axis view, so the donut, and here's the long axis like the football, and this is some of that area of enhancement, and there's that thrombus or blood clot. So here, this is mainly just put in to show that there is not a single best test. Right? There's a best test for most clinical scenarios, given the patient characteristics, what the clinician is concerned about. But all of these tests have value and have a place to be used. And when I'm not being a cardiologist, my wife, Allison, is also a physician, and my children, Annabelle, who's 9, and Serena, who's 5, we try and get out on the ski slopes as much as possible. And that's our dog, Apollo, who dressed up like a lion for Halloween. And with that.
Wonderful. Thank you so much, Dr. Wasserman. That was absolutely fascinating, and so appreciate your expertise in these areas in cardiac rehab. We may see some of these once in a while, and we're like, we have no idea what this is showing us. So we
always
really
happy to help out.
We like the summary right at the end where you interpret. It's fantastic. Yeah. We really appreciate your expertise in all these areas. We do have a couple of questions. The first question here, they're asking if there are any statistics on what happens when patients with a calcium score higher than 100 gets on aspirin and statins and aspirin. In other words, do they have heart attacks later?
So there is risk reduction in patients that have positive coronary artery calcium scores. For patients that have intermediate risk, 0 to 100, usually we would rely somewhat on the atherosclerotic cardiovascular risk disease score that's used before to see how much risk was there. And most of the time, based on those results and the CT results, in addition, if they have any significant family history, there's shared decision-making, and most of those patients do get statins. There are statistics. I cannot quote them off the top of my head, but the general principle is the higher risk somebody is to have a heart attack, the more benefit they get from medications. So patients that have already had a heart attack get the most benefit from statins and aspirin versus, and that's why we don't put quote unquote medications in the water. So the higher the risk, the more the benefit. And usually with an intermediate calcium score, it's shared decision making, and most of those patients do qualify for statin therapy.
Wonderful. And a lot of times what we'll say too is, you don't really know what your event is going to be or when, but having anything that's preventable, or if you can do what you can to prevent it, it may be less if it's going to happen anyway. So we're thankful for having new tests to help us determine our risk. Another person was asking, do you use FFR with CT angiography? I know they use it with regular angiograms.
We do. So I thought that was a little bit beyond the scope, just of given the amount of topics we covered. But FFR is fractional flow reserve, and it was first developed in the cath lab, and it's actually using a special pressure transducer to calculate the flow before and after the lesion, because you can imagine on catheterization, we're seeing a two-dimensional picture. I mean, usually get multiple, but it can be hard for moderate lesions, to decide if they're significant enough to fix or to treat medically. So FFR gives a quantitative analysis where we're looking at the hemodynamic consequence, which ultimately is what we care about, right? So if it's a 70% blockage on an angiogram or a CT scan, but it's not compromising the flow, that's less likely to be significant than a 50% blockage, quote unquote, that is compromising flow. We do use CT-FFR. CT-FFR does not actually measure flow. It measures the size of the vessel before and after, and then uses an algorithm to determine what the FFR would have been on the catheterization, is my understanding. We are using that, yes. Usually that's patients that have a known lesion, so they have a cardiac catheterization that shows an intermediate lesion or multiple lesions, and it can be used to better quantify, the expected benefit of fixing those.
Wonderful, thank you. This one next question is, what tests are best for aneurysms?
Well, it depends on the type of aneurysm, and it depends on the severity. In general, a lot of times we pick up, I'm going to assume this is aortic aneurysm. If you have an aneurysm of the heart muscle, an echocardiogram is typically the test of choice. As far as aneurysms of the aorta, oftentimes they're picked up on an echocardiogram. Very often cross-sectional imaging, so either CT angiography or MR angiography will be performed. And the definition of what is an aneurysm has changed. We're looking a lot more at indexed values now, so dividing the diameter of the blood vessel by the patient's size, body surface area, to look at it. But usually if there's significant aneurysm, either a CT or an MR angiogram is done at some point and often is followed going forward if there's a significant aneurysm.
This one's a little bit more technical, talking about high velocity. They're wondering, when does high velocity or high cardiac output become concerning?
So high velocity becomes concerning if we're worried about valve dysfunction. One of the reasons you can have a high velocity is if you have, very high cardiac output. Most patients don't have very high cardiac output at rest. Typically when we see that, it's patients that have like an AV fistula for dialysis, which is a type of shunt. Sometimes patients with severe anemia. When we're looking at high cardiac output, oftentimes the problem is not the heart in that respect. It's either there's more demand for oxygen, the heart's doing its job. Oftentimes what we'll do is compare the velocity in different parts of the heart. And if it's high, in the chamber and in the valve, usually that's more likely to be just increased cardiac function than it is when part of the blood flow is normal in part of the heart and then high at the aortic valve. Usually that's the aortic valve disease. But rarely am I concerned about high cardiac output unless there are very specific other factors that I'm looking at.
Thank you. This next question talks about really understanding the tests. And, even when we're in the medical field, it is hard to understand what these tests are really going to show us. So they're asking, are there ways that they can become more educated in these tests? Or is it really, when you're sitting in front of your doctor, is it just a trust factor? Do you just have to trust what the doctor says?
Well, I would say it's always good to educate yourself. And there's a lot of information out there. Some of it's good, some of it's bad. I find that the Mayo Clinic and Cleveland Clinic in general have a pretty good patient education for things like this. Also, your provider has access to up-to-date and other patient resources that they can give to you. Normally, when we're talking about cardiac imaging in the outpatient setting, we're not talking about an emergency. So there's time, I don't think that it's reasonable to ask patients to go in and know everything about every kind of cardiac testing when they see their doctor. But if the doctor recommends a test, it's totally reasonable if there's disagreement or questions to, learn about it and, get back to their office with an opinion, most of the time. So I think that, that would be my recommendations would be ask the provider for some information that they can get you. And also at the Mayo and Cleveland Clinic sites tend to be good. There are a few other ones too. I can't think of the top of my head, but, I wouldn't rely too much on message boards and forums and things like that. Because everyone's experience is going to be different on the patient side. But there are big clinical trials and good data about, what to do. And there are a lot of times when patients don't fall within that exact, clinical trial inclusion criteria. So, there's one of 2 or 3 tests that we could do. And there may be a specific reason why the clinician or the patient thinks one is better than the others. So in the outpatient setting, there's time to read and think about it.
This next part of the question is really from a patient perspective. I'm not sure if you have insight on it, but it does, talk about insurance companies and what's being covered. I know some of the newer tests, it takes a little bit longer for the insurance companies to get on board with regard to benefit versus an older test that may be covered. Where are we with that? Are some of the insurance companies giving pushback on the newer testing, the CTs and the MRI testing?
So MRIs and CTs, definitely MRIs, and I believe CTs require prior authorization to get done. In general, echocardiograms are pretty much covered by everybody. Stress testing, even nuclear stress tests, can be difficult sometimes. An insurance company will want a treadmill stress test to be abnormal first. Catheterization tends to be covered. It's different for everyone's insurance. And, it's kind of on a case-by-case basis. But, the newer the testing modalities, so CT and MRI, the less excited insurance companies are, to pay for it without some sort of prior authorization or, information sent to them.
Well, thank you. And we get frustrated too, because some of those tests seem to be even more beneficial, giving you more information in one shot. So this next person is wondering if a tumor versus a blood clot, do they look different or the same on imaging?
Depends on the modality of imaging. So I'd say in general, cardiac MRI is the test of choice to look at cardiac masses. And that's because with the different sequences, we can really determine what the cause of, we'll call it density or a mass in the heart is. Cardiac CT is very good for blood clots, for thrombus. Echo is good, but you don't get tissue characteristics as well. So the actual characteristics of what's inside or what's making up the mass, you don't get as well, but usually cardiac masses are picked up first on echo. And then oftentimes they'll go to MRI or sometimes to CT afterwards.
Wonderful. Very good. I'm going to leave it at that. We are at our 1:00 hour. So again, I just wanted to really thank you for your expertise today. I know that some of the information is challenging for just kind of the regular person to understand, but you did a fantastic job in explaining it. And I just wanted to remind everybody too, for those that need a refresher on this or would like to look at specific areas of this topic, again, it is recorded, so it will be available on the Bay State Health website as well. So thank you all for joining us today. We appreciate your time, Dr. Wasserman, and we hope to see you soon. Thank you.
Thank you all. Have a great day.